Professor Allan Young, an international expert in bipolar affective disorder. Absolute delight that you are here with us, and this is the third episode of our interview where I'm going to discuss some controversies. Allan, there's a growing concern that emotional instability or complex trauma is mislabeled as bipolar affective disorder, especially in young people. On the other hand, many individuals with bipolar affective disorder go undetected, undiagnosed for years. How do we strike a balance as we learn more and more about the impact of trauma and emotional dysregulation?
Sure, I mean, that's a great question and a very thorny clinical area. One of the first things to recognize is that the literature shows that there's what we call a comorbidity between emotionally unstable personality disorder and bipolar disorder. And this is perhaps as high as 20%. So 20% of people with bipolar disorder would also meet the criteria for emotionally unstable personality disorder. However, I think there's something that's very important to recognize in psychiatry, in that you understand the individual and their disorder much better with longitudinal follow-up than looking at on a snapshot basis. And I think the epidemiologists would agree with this, people like Martin Preissig and Brendan Penix and so on. So one thing that we often see is that someone who appears to have bipolar disorder and emotionally unstable personality disorder, when you follow them up and they're treated and the bipolar disorder resolves, then so does the apparent EUPD. So that to me means this isn't emotionally unstable personality disorder, because that would be a stable trait. The contrary can also be true. The person can, the bipolar disorder can resolve and they can still have EUPD. In that case, it would be a proper comorbidity. I think very often clinicians get themselves into a bit of a tangle with this because they think they have to make an either-or decision. It's either bipolar or it's EUPD. But if there's evidence that both are there, then that's the way you should proceed. I mean, I've had patients with established bipolar disorder who've seen other clinicians, because we're a tertiary clinic and they may have local care. And I had one lady who's a healthcare professional who I've always thought has bipolar 2, but when she's unwell it can manifest in ways that are similar to EUPD. And she had a new locum consultant who said, "Oh, Allan Young was obsessed with bipolar disorder. You don't have that, you're a personality disorder," after speaking to her for 20 minutes. So we've got to beware making snapshot judgments like that and be willing to tolerate the uncertainty until things become clear. Now, the role of trauma is, first of all, there's no doubt that childhood trauma is quite clearly present in many of our patients. I think the figure is about 38% or more of people with severe mental disorder,
probably more, I would say,
report childhood trauma.
Yeah.
We've got to be slightly, when we're thinking about this academically, we've got to be slightly concerned, because there's recent evidence that trying to ascertain childhood trauma retrospectively with things like the childhood trauma questionnaire may not be accurate. It may not link with actual reported childhood trauma. So my colleague at King's, Professor Andrea Danesi, has done some very nice work looking at this and has shown that childhood trauma questionnaire showing childhood trauma may be reflecting current mood state rather than actual childhood trauma, because one thing that happens is people are depressed, they look back, and people seek a narrative and a reason for things and so on and so forth. Nevertheless, there's good objective evidence that childhood trauma leads to an increase in mood disorders, and I think it, in adult life, perhaps increased as much as 4 or 5-fold. And also I think it makes people less likely to respond to treatment. So it's a big issue. I don't think in terms of therapy we're very advanced in that. There are particular therapies that people talk about. I think things like mindfulness-based CBT, we've just published a trial in Lancet Psychiatry. I was one of the group that did it. That was really done mostly by my colleagues. mindfulness-based CBT seems to be particularly helpful where there's evidence of childhood trauma, more helpful in CBT. So I think there are things that are advancing, but I would beware about dismissing people as, you know, just a personality disorder, which of course, even if there is only a personality disorder, should never be treated that way. But very often there some clinicians do that, and I don't think it's very helpful. So I think you need to follow your patients up to understand what's going on.
I completely agree with you. There's more and more recognition of neurodiversity in the past, especially since the pandemic, in my view, or just before the pandemic. Maybe the pandemic just brought out the awareness because of home working, etc. And emotional dysregulation is also a feature of attention deficit hyperactivity disorder, and sometimes also of autism in many situations. How would we differentiate between bipolar affective disorder and neurodiverse conditions?
Well, people with neurodiverse conditions can have bipolar disorder. So, I mean, I think if there's evidence of both, then that's what's going on. I mean, particularly with ADHD, we know that in complex and treatment-resistant mood disorders, depression and bipolar, there's very often unrecognized ADHD. And we currently have a trial that we're doing with colleagues, Professor Stephen Marwaha is leading it from Birmingham, looking at treating ADHD in people with bipolar disorder, the SNAPPER trial. And similarly, you get ADHD, which may be unrecognized in treatment-resistant depression. My own view is that ADHD is, at the moment, both under and over-recognized, which sounds like a strange thing to say, but I think within people who've got particularly severe mood disorders, it's unrecognized because it's thought, oh, it's all due to the depression or the bipolar. I think there's a tendency for mental health, psychiatric conditions in general, to drop the thresholds. So many people who would be considered to be in the normal range before have got, are now being told they've got ADHD on the basis of essentially screening tools. I mean, you know, my view, and I work with people who are experts on this, Professor Philip Shaw and Philip Asherson and so on, they say the screening tools are good for screening, but you need a proper
assessment.
Proper assessment. So I think that's ADHD. Autism, we're much more aware of autism than we were in the past. I think that's a good thing. I think autism brings with it sometimes great blessings. People can, you know, benefit from aspects of the autism, but it can also bring problems, especially when it's comorbid with a psychiatric disorder. And then there's other aspects of neurodiversity, things like dyslexia, dyscalculia and so on. We're just coming to grips with this, and I was talking to my colleagues recently about the changes and the way we've got to change the way we deal with each other in institutions and settings. And, you know, previously it was obvious that neurodivergence was there, but it was just never talked about or recognized. People were considered to be a funny kid or this, that, or the other. And so we have to recognize this, we have to take it into account. I would go far to say maybe our concept of normality is a bit not fit for purpose. I mean, you know, if our concept of normality is you've got to be perfect in every way, that certainly doesn't apply to me, and we just need to be aware of these things. But we've also got to be aware about dropping thresholds and pathologizing everyday experience. And we're seeing a lot of this with anxiety in young people. I think it's made worse by COVID, certainly in the students, because, you know, every psychiatrist knows that the best treatment for anxiety is exposure, really. And of course, if you are not allowed out the house to interact with other people, and there's a huge emphasis on mental health, and you're told that anxiety is pathological, then normal experiences are pathologized, and that's not going to be helpful for anyone, really.
You're absolutely right, and I think as a society we probably need to be more accepting of spectrums of normal, as you say. We need to change the view of normal, and people are on a spectrum and recognize diversity amongst people. And when I talk about diversity, I'm not just talking about cultural diversity, I'm talking about diversity in every sense, whether it's neurodiversity or or other, and I guess that would make a fuller society.
Yeah, absolutely. I mean, a very trivial example is diversity of daily rhythms, because we know there are certain different patterns, and you could summarize it very briefly as being a night owl or a morning lark. Now, I'm somewhere between the two, but I was just writing a grant with two night owls, and personally I find it difficult to keep going after midnight, but they'd be sending me emails at 3 in the morning, but then I'd be up, doing things again at 7 o'clock, and they would be out of commission till maybe 11 a.m. So this is just part of life, and it's part of life to be aware that everyone's different, and we're all different in different ways. We need to be tolerant and understanding about it, and not pathologize it too much, really.
Yeah, I agree with you. How do you think media portrayal of bipolar affective disorder has affected perceptions of people?
Well, generally, I think the media gets mental illness wrong. I mean, it's difficult to think of any examples where they've got it right. It tends to be, they tend to be wide of the mark in many different ways, and this is also true for bipolar disorder. And I think it's a curious phenomenon whereby a lot of people think that they intuitively understand and know all about mental illness, when essentially they don't. I mean, I was at a dinner party once, and I was being lectured about bipolar disorder by someone who didn't have it, and none of their family did, but they'd read an article. And my wife said to me afterwards, "I don't know why you studied for 20 years, Alan, when you could just have learned it all in one dinner party from that person." So we've got to be aware that there's a body of evidence, there's experience, we can learn about this and be a bit more humble about the limits of our knowledge. But I think generally the media and the movies and so on, they've got a long way to go in accurate portrayal of problems that people grapple with, really.
On the other hand, media can be a very powerful tool to
Absolutely.
portray and destigmatize
Absolutely.
if that is the journey they wanted to
Well, I
take.
talked about Margaret Trudeau before, and Margaret's, I mean, it's 15 years or so ago that I did this with her, but Margaret's public lectures and her accounting of her experience, which is absolutely authentic because it's her experience, it's not someone's turned it into a movie, that was incredibly powerful. So I think that's the type of thing we need to see more.
A little bit more,
Yeah,
yes. If there was one myth you wanted to dispel today, Alan, through this interview?
Well, I think the aspect in the first, sometimes years of bipolar disorder that's most damaging is denial. I think the idea that you're well and therefore you're going to be well, and you, as one of my patients said, I'm sacking this illness, and you say, well, that's just not going to work. So I'd like to, I mean, you really have to understand the condition that you're suffering from, and people need to take responsibility for their own health, really. Do everything that you can to try and preserve your health. I think that's absolutely vital, really.
As you would for physical health, right? We have diabetes,
yeah.
we have cancer, we can't sack these conditions, but what we tend to do is do our best to manage it.
Well, absolutely. I mean, there's been cases of celebrities who, I mean, the tragic case of Steve Jobs, who I understand had a treatable form of cancer, but went off and wanted alternative treatments until it was so far gone that the conventional treatments wouldn't work. So I think we need to educate people about what is good evidence and is good science. I mean, I think this is really important. And, this is a battle that we have to fight in the media, because we have, I think, some bad actors, and they may not be purposely bad actors, but some people who spread disinformation about these disorders, and we need more knowledge, more understanding, and probably more compassion.
I agree. Different people have different perspectives, right, and different way of looking at the world, but I guess what you're suggesting is not to throw away that might be helpful, at least,
Sure.
Consider the evidence base behind it.
Yeah, absolutely. And I think also an understanding of what evidence is. And, I remember during, I think it might have been COVID, there was a saying, the science is settled. Well, one thing I've learned is the science is never actually settled. That's the nature of science. It's always provisional. It's always got to be questioning. I was asked about why we should promote scientific integrity in universities. And I said, well, because it's not science that doesn't have the integrity, it's the scientists. So if I go into the lab, which I don't do anymore, and I discover something and I think, well, if I just threw that bit away and I could just report that bit, publish it in Nature, my name would be in lights. Well, what will happen is it won't be reproducible. People will understand that this was a badly done experiment. So we've seen that. We saw it with the dreadful case of that very shoddy publication about vaccines and autism, which was really should never have been published really, and was shown to be not true essentially. So I think we need more understanding of what science is. Science isn't a judgment from some higher power about what's right and what's not correct. It's actually a human process that tries to get closer and closer to the truth, although we probably will never absolutely get there.
No, it's a dynamic process.
Sure.
On that note, thank you so much, Allan. I'm genuinely honored, privileged, and thankful to you.
Well, thank you very much.
And for your time.
Thank you for asking me.
You're very welcome. So please subscribe to the channel if you enjoyed today's video. Please don't forget to watch the previous 2 videos with Allan. It's just a lot of information on bipolar affective disorder. Like it, share it, tell it to all the people you know. And thank you for watching.